shouldn't know I'm going to say this, but I'm going to say it. So my friend said, oh, you got to try this AAIT thing, blah, 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 blah. I was like, okay. I was in a bit of a daze because I just lost a parent. So I'm sort of like, I don't know, I've been traveling back and forth. I'm an only child. I don't know. I don't even know if I slept for like a year. And I'm like, okay, so we go to this, you're in trouble. We go to this session and she starts doing this and I'm thinking, I gotta get out of here. And I gotta get my money back. Because I'm an evidence-based practice person. Like, I'm a social worker. My code of ethics says I've got to have empirical evidence to do something. I can't just do whatever I want to do. And it's not okay for me to my clients. I got to know when I offer them something, there's a real possibility it's going to help them. Right? Not because I like it or they like it. I mean, that's a plus. But there's a lot of people out there who've tried it and tested it, and they're like, I keep getting some good outcomes. I'm going with that. You know, that's better than a frog on my head. You know? If there's evidence of that, I might try it, but today there isn't. Right? So I'm sitting in this room and thinking, I gotta get out of here and get my money back. So she says we're going to do this process, which we're not going to show you here. You hear the word process and protocol. Those are the words that you're going to hear a lot because that is the iterative process, the questioning in a specific order with a particular repetitive approach that we utilize a lot. And she's sitting here saying, we're going to use this process and it's really good with grief. And I'm like, I'm going to volunteer. And I've had a lot of therapy. It takes a lot to hold me together, you know, and I know some of you are nodding because you know me. And I've had therapy for years. I'm going to go to therapy when I do this work because it's part of my self-care, right? So I'm in this room and I'm not a crier. I mean, I don't like not cry. I'm very in touch with my emotions. I can be emotional, but crying, not so much. My dad's gone. I'm having these crying spells where I have to leave work. And some of you I've worked for, you know, I'm like practically throwing up and I go about throw up, come back to work, you know, that's a whole other group therapy too. But I'm working and I have to stop and go have these sobbing spells and I cannot get them to stop. So I'm like, okay, that's what I want to work on. Haven't had one since. I didn't believe you could do anything once because I got to work, I got to be, you know, in pain. It's going to take a lot of work to get something done. And that made me go, And then I started trying it. And you saw the information that Melanie just presented to you, those outcomes. Yes, they're anecdotal. Those are, some of them are from another research project, talking and interviewing qualitative work from another professional in the field, collecting information. And I'm like, I gotta see if this is an evidence-based practice. That is a charge of my code of ethics. So that's what I wanted to do. So this is the study to see, you know, do I need to go and, yeah, this is really cool, but I'm not sure the processes are the reason for change. Maybe it's something else. So here we go. So I developed this research project called Acceptance and Integration Training for Rumination and Depression with college students in a pandemic. Take a breath. And here are my questions. Are acceptance and integration interventions associated with a decrease in college students' depression scores from pre-test to post-test? Are acceptance and integration interventions associated with a decrease in college students' rumination scores from pre-test to post-test? Things we're not going to be interested in, but I'm going to say them. Are COVID stressors associated with their depression and with their rumination? We're not going to talk about my last two questions because it's Friday, right? And we want to get to, ooh, I'm breaking stuff already. I usually wait until the last 30 minutes to do that. So we're going to wait, right? We're going to focus on what you clinicians may be focused on and can use. So here you can see, and I'm not going to read everything off this slide, and I know you're happy. The design that I utilized was a quantitative pre-test, post-test, quasi-experimental design. There was no random assignment or control group in the sample. There was non-probability, and it was convenience sampling, so it was students on campus, because this had to be conducted in an organized manner, and it was part of, my getting my degree. And then you can see the other elements there and the exclusion criteria to be focused and to keep our students safe. Once students qualified to volunteer for this, they attended a 3-hour skills training session. And this session was led by, not me, but a licensed clinical social worker, Sarah Reidner, who's trained and certified in this particular modality. She conducted the skills training. It began with I said it was 3 hours already, with the pre-test. And I will talk to you about what the measures were that we utilized in that. But we looked at a test to get their depression scores and rumination scores. That was followed by a psychoeducation session talking about what specifically rumination is and depression, how they're connected. Then Sarah explained into words and demonstrated it with a volunteer in the session, allowed them to ask questions. They had a handout so that they could follow it. Then we helped them activate their own ruminations. They made a list of what are the things that you ruminate on the most. What is something you're ruminating on right now or today or recently? And then really asked them to feel that, bring it alive for them in that moment as best they could. And then they independently practiced using end of words. And then we took a break, yippee. Followed by another protocol called Deep Peak 2 that we will demonstrate next. That was also demonstrated with a volunteer by Sarah. Once again, rumination was activated. The volunteers practiced using Deep Peak 2 with their ruminations, and then they took a post-test. And here's what I investigated in my measurement. The demographics, which you can read there, that's listed. The COVID stressors, which come from some questionnaires. Again, we're just going to scoot on past that, but I want to tell you it's there. The depression, I utilized a questionnaire called the State Depression Scale. And I will, if anyone wants access to this, if you want to utilize this in your practice, it's a pretty easy one to use. I could give you access to that. Sorry, I left it off the slide. Oopsie on me. But it is a very easy scale. It has 20 items in 2 subscales. 10 of the items are dysthymia questions, associated with depression. Statements like, they're not questions, they're statements. I feel depressed. I feel sad. And then the euthymia are the more like normal or stable state. I feel strong, I feel clear-headed. And this is designed to look at their current depression in this moment. And rumination was measured by the Brief State Rumination Inventory, which is an inventory with only 8 items on the scale. And that really is created to focus and capture like that maladaptive momentary occurrences like we talked about with ruminations of thoughts, focusing on distress, the problems, and its causes. So here are the results. To address the first question that we're focused on, are acceptance and integration training interventions associated with the decrease in college students' depression scores from pre-test to post-test. In the analysis, I utilize an exact sign test here, and the outcomes were statistically significant. So that was very exciting for me, because that's what I was hoping for. Not only in the whole state depression scale, but in both dysthymia and euthymia. And some might say, how can that go down? Wouldn't you want that to go up? But it was reverse scored. So you wanted to see a negative score. You wanted to see them both go down. So that was very exciting. And now I'm like, yay, I passed. And then the next question that we're going to focus on today are acceptance and integration training interventions associated with a decrease in college students' rumination scores from pre-test to post-test. This, we used a paired sample t-test, and we discovered a statistically significant mean decrease in their pre-test scores of the brief state rumination, which was also very exciting and caused me to be very thirsty. So I was pretty excited because this statistical information indicated something is going on here, right? Let's pay attention. The outcomes and conclusions that I was able to draw from these statistical outcomes, you can see here in front of you on the slide, that these protocols, right, led to a decrease in college students' depression and rumination. This is also important because it adds to that research gap, not only just with AAIT, but also with college students. Surprisingly, there's not as much information as one would think. And also, it really also added to the internal consistency of this particular measurement tool, which I like because I like to use outcome measures with my clients to know, are things changing or do they just like me or quit coming back because they're miraculously cured, right? Which of course doesn't happen. So I found this to be very exciting and important information, particularly in building this evidence base for AAIT. It says that protocols used in AAIT can be effective for addressing depression and rumination, right? It's important for us to do further research on this model moving forward. So when I think about all the stuff here on the slide, what this says to me in terms of outcome is that there was statistically significant change in depression and rumination when protocols used in AAIT, and that protocols used in AAIT could be effective for addressing these constructs. Now, this was with college students, so I can say that about college students. We got to do more work to generalize it to others, because I don't want to, say something that I don't have enough evidence to make that huge leap yet, because we're just going to start where we are, and it was a small group. And these findings support rationale for further research of this as a psychotherapeutic model. So my conclusions are that it provides support to identify AAIT as a psychotherapeutic intervention that we can use to address depression and rumination. Increases in depression and the identification of rumination as a risk factor for depression, this research really provides a lot of promising support for this approach to address rumination and depression with efficacy. And that was my exciting moment because I didn't want it to just feel good. I wanted to know it was going to be effective.